right, is this about the group that's going to be here? Okay. I'm Ben Abrams. I'm one of the cardiac attendings. We'll talk about pulmonary physiology today. Unfortunately, I have a guy we're about to put on ECMO and then do a case in the cath lab, so I have to duck out a little early. But we will finish things up in the afternoon, and the PBLD I have is pretty short, so we won't be here all night. So I think basically the goal will be to try to get through shunt and hypoxia, and then in the afternoon we can finish some of the dead space and go through the PBLD. So as the outline, you guys got the outline that we sent out? Okay. So very, very briefly and superficially, to make gas exchange happen in the lungs, we have to continually wash out gradients from both the alveoli and the pulmonary vasculature. So they're basically countercurrents. Primarily, we care about oxygen and CO2. You can read all about Fick's law. It's pretty self-explanatory, but we need to maintain gradients. We need to make sure there's a nice surface area in the lungs for gas exchange to occur. We need to make sure that that tissue isn't too thick, so pulmonary edema, ARDS, things like that can affect solubilities of both gas and exchange. And then there are slight differences in some of the solubilities of the gases that we care about. So oxygen is actually much less soluble than CO2 in the tissues, and this clinically manifests, as we'll chat about, with where VQ mismatching actually becomes relevant for each gas. And I think some of the semantics can get a little confusing with VQ mismatch, so hopefully we can clarify some of that because people get a little bit lazy in terms of what they call what. So I went through the West zones a little bit in the pre-reading outline. Did you guys all use that J.B. West pulmonary physiology book in med school? No? Yeah, the little red one. It's pretty solid. If you don't have it or you haven't looked through it, it might be worth some of your education funds. But essentially, J.B. West back in the day described 3 zones. There's now possibly a 4th zone, of course, of how our ventilation and perfusion lines up. The thing to think about is that his descriptions and assumptions are in people who are either standing or sitting upright, which is not most of our patients. So we'll flip things around when we start to talk about how people look in the OR. But essentially, zone 1, and for now we'll assume an upright person, is where the alveolar pressure is greater than the pulmonary arterial pressure, which is greater than the pulmonary venous pressure. So what does this mean? Essentially, the alveoli are physically compressing the pulmonary arterial bed, and so you're not getting perfusion there. So when you look at VQ ratios, this is essentially the definition of dead space. So as perfusion goes to 0, that ratio goes to infinity. We'll get through some of the logistics of what that means for gas exchange. But in a spontaneously breathing person, zone 1 does not exist. Can anyone explain why that might be?
Because like when you add positive pressure, that increases alveolar pressure, increases compression.
Exactly. So the inverse is that someone has to be on positive pressure to have zone 1 physiology. When we're spontaneously breathing, we're generating negative intrathoracic pressure. So there's no way to have a negative pulmonary arterial pressure. And so this doesn't exist for spontaneously breathing people. It becomes more relevant for us in the OR because a lot of our patients are on some sort of positive pressure. Zone 2 is where we optimize gas exchange, both oxygenation and ventilation. So here our arterial pressure is greater than the alveolar pressure, so we have some perfusion through these zones. But the alveolar pressure is maintained greater than the pulmonary venous pressure. So VQ here sits right around 1. There'll be perturbations in either direction that we'll discuss a little more this afternoon. But this is where we hopefully will keep people. So what can adjust these ratios? if the RV starts to struggle and your PA pressures go down, you can potentially shift where your zone 2 actually lies. So if especially again, someone on positive pressure isn't able to generate a pulmonary arterial pressure that's greater than your alveolar pressure, or you're really beating someone's lungs up with the ventilator, then you're going to throw people in and out of zone 1 and zone 2, and it's going to affect your VQ matching. Zone 3, your pulmonary arterial pressure, again, is the highest, but now your pulmonary venous pressure has exceeded your pulmonary alveolar pressure. So in cases where you've got a high wedge pressure, such as someone in left heart failure, you'll exceed your venous pressure, will back up and start to then physically occlude alveoli. This is probably clinically doesn't happen all that much. What probably happens more is what now people are describing as zone 4, where I think this was in the handout, but your pulmonary arterial pressure then exceeds your pulmonary interstitial pressure. So they've added an interstitial pressure in there. That's where your wedge is high and you've started to white out lungs, and people are in pulmonary edema or ARDS, that type of situation. But the traditional description of the West zones only includes these 3. So this also is a classic figure from how J.B. West described this VQ matching concept. Again, realizing how people are positioned and how rib numbers become relevant is important, and it's different for how most of our patients are supine in the OR. But along the right here is up. Oh, sorry.
You're doing such a good job.
Hey, thanks. Was the last figure at least showing up there? No? Okay.
You got a glimpse of that.
A glimpse. Well, this was in the handout, so you might remember what we were discussing. This was the last slide we were talking about. So this is the a VQ matching chart for someone who's standing upright. The lower rib numbers are up toward the head. The higher rib numbers are caudal. And so, as you can tell, down toward the bases of the lungs, you have higher blood flow, which is due to gravity, but you also have higher and more efficient ventilation, alveolar ventilation. Can anyone explain why that might be? Why you get more bang for your buck, essentially, with alveolar ventilation down toward the bases? So alveolar ventilation is certainly depends on your respiratory rate, but it also depends on the sheer change in volume of alveolus. So we think about atelectasis happening at the bases of the lungs in someone who's standing upright. But if the alveoli starts at a smaller volume, expands to a larger volume, and then goes back down to that smaller volume, as opposed to alveolar beds that are more up at the apices that might not actually collapse much, they're kind of staying at a not fixed, but a larger volume overall. There's less alveolar ventilation happening up here as opposed to down at the bases where you're getting more expansion. As we move up toward the head with lower rib numbers, the effects of gravity and blood flow are more pronounced compared to where we get with ventilation. So that's why, again, there's a lot of assumptions here, but around rib 3, we get our optimal VQ matching, which is VQ closer to 1. But as the pulmonary blood flow really drops off, getting up toward the apices, your VQ ratio actually tends toward infinity. And so the opposite happens if we think about a supine patient. We're no longer thinking about rib numbers. We're thinking lower rib number is equivalent to our anterior alveolar beds, and then the higher rib numbers or the apices now become posterior. And if we start flipping people or proning people in the ICU, then that all kind of changes. But this is where some people get a little confused about where the VQ matching actually happens because it's usually described with rib numbers. All right, so what does VQ mismatch really mean? So a pure definition of VQ mismatch just means that your VQ ratio isn't 1. So it's not, our ventilation and perfusion are not perfectly matched. What happens clinically is that a lot of people will equate VQ mismatch to shunt. And so that's where we have perfusion without much ventilation. Okay. Sure. So I think people get a little confused when people will just throw out the term VQ mismatch and someone's hypoxic because any VQ that's not 1 is technically VQ mismatch, but in general, most people will equate VQ mismatch to shunt, which is a VQ ratio that tends towards 0. The other thing, as we're defining ventilation, the ventilation part of VQ mismatch that people get a little bit confused about is that the pure definition here is ventilation is just gas exchange. But a lot of times in the OR, people will talk about ventilation purely as getting rid of CO2. So don't let that be a source of confusion either. Ventilation, V here, is gas exchange, whether it's oxygenation or ventilation, just moving air in and out of alveolus. And then again, VQ less than 1 typically is VQ mismatch and shunt. And we'll get into dead space more this afternoon. All right, still struggling a little bit. So this is again a diagram that was in the pre-handout, but it shows as we trend toward VQ, either an infinite VQ or a VQ of 0, what happens in terms of dead space and shunt. So this morning we're going to focus more on shunt effect on the left side. So we are maintaining perfusion but losing ventilation. And what your body naturally tries to do and what makes the lungs unique with respect to their response to hypoxic conditions is that your pulmonary vasculature actually clamps down in the setting of hypoxemia, as opposed to most of your other tissue beds will try to vasodilate and optimize blood flow. Again, the goal is oxygen delivery. So if you have hypoxic blood but you deliver more of it, you may maintain tissue perfusion. But here, since we don't want to actually deliver blood to areas of lung that are not exchanging gas, because that increases our shunt, the lungs will actually clamp down those regions. And we'll chat a little more this afternoon. Some of our anesthetics, some of our inotropes, some antihypertensives will actually impair our normal hypoxic pulmonary vasoconstriction, so we can kind of chase our tails round and round in certain situations. So again, we'll just focus on shunt this morning. So this is where ventilation and perfusion ratio trends towards 0. So we're getting perfusion without ventilation. So clinically, this is situations where we're atelectatic, we have pneumonias, a main stem intubation, or potentially we're purposefully on one lung ventilation for thoracic cases. We'll talk about shunt effect versus a pure shunt, but situations where you have either abnormal anatomy or normally with bronchial vessels, and you have perfusion that goes right to left without even touching an alveolar bed, is a pure shunt. So congenital heart disease, VSDs, ASDs, more complicated things that we'll not touch on today are pure shunts. Everyone has some pure right to left shunt with bronchial vessels, which are normal circulation that oxygenated blood actually still perfuses your lungs, and then deoxygenated blood gets dumped into the pulmonary veins. Essentially has not picked up any oxygen, so that's a pure shunt. Some cirrhotics get AVMs throughout their pulmonary vasculature. That's called portopulmonary shunt. And these are just a few examples. And again, we'll get to dead space this afternoon. So this is a little more about what the difference between absolute shunt and shunt effect is. Clinically, and on tests where this comes up, is that someone with absolute shunt, so essentially you are not ventilating the tissue beds that you're perfusing and talking about, will not correct by increasing FiO2. So again, the patient with an ASD is probably the easiest way to think about it. So deoxygenated blood is entering the right atrium. Depending on which direction, it's going to be a right to left shunt here. The blood actually goes. The deoxygenated blood enters the left atrium, left ventricle, and gets perfused out to the body. So it's never touched any alveolus. It's never touched any gas exchange. So the ventilation is 0. So your VQ ratio is 0. So you could have someone on an FiO2 of 100%, and none of this is ever going to change. What we typically deal with more often clinically is this shunt effect, where the VQ ratio is somewhere between 0 and 1. So we still have some amount of gas exchange, and the Q portion, or what we're perfusing, actually is touching the alveolus. So if we increase our FiO2 to a certain extent, we will be able to improve oxygenation. But certainly on the extreme end of the spectrum, clinically, we won't make much ground. So here's atelectatic lungs, pneumonia. More semantics that sometimes get mixed up is, and for whatever reason, the ABA seems to call shunt effect venous admixture. So you can tuck that into your brain. If you see this term venous admixture, it's just the same as shunt effect. Save this for this afternoon. I will say on every one of your ITs and your board exams, you will get some sort of change in terms of looking at spirometry in pregnant patients. 100% of the time, you basically will just have to memorize this chart. I'm not going to read it through you this morning, but that will be high yield for any of your board exams. All right, so now that we have a little better handle of what VQ matching means in terms of oxygenation, we can talk about clinically where things can fail and our VQ matching and shunt effect can occur. So certainly at altitude we have, or let me back up, low FiO2. So any type of leak in the system, a failure, I'm sure you guys have been going through with all of your machine checks. Low FiO2 is going to cause hypoxemia. Again, more toward the V side of things for the VQ ratio. Hypoventilation, which we'll get into a little more looking at the alveolar gas equation, can cause VQ mismatch and hypoxemia because essentially the CO2 will take up space in the alveolus that oxygen is not able to maintain, and so you won't have your alveolar gradient to exchange oxygen across your capillary beds. Hypoventilation gets a little more complicated because you need to consider what's causing the hypoventilation for someone that's spontaneously breathing versus someone whose respiratory rate we're actually controlling with a ventilator. And that gets into some PACU stuff that I'm sure one of the lectures goes through. Impaired diffusion gets into Fick's law a little bit more closely. So if there is a greater distance for your oxygen to have to travel to get from the alveolus into your pulmonary arterial tree, so for example, pulmonary edema or IPF patients, if you have decreased surface area, either from emphysematous lungs, someone's had a lung resection, atelectatic lungs have decreased surface area. And then in cases where you have impaired oxygen uptake because you have a low hemoglobin, you have a high cardiac output, you have any type of shifting in your oxyhemoglobin dissociation curve, also will impair diffusion across those tissue beds because you're not going to uptake as well. Venous admixture, which is shunt effect or VQ mismatch. Again, we talked about pneumonia, atelectasis. We'll talk a little bit more about how dead space can actually cause VQ mismatch this afternoon. But again, RV dysfunction or PE, where you're not going to perfuse, you're not going to ventilate, you're not going to then oxygenate, can cause some of these situations. And then absolute shunt or pure shunt are some of these congenital heart diseases, mainstem intubations, pulmonary AVMs, like you'll see in cirrhotics with hepatopulmonary syndrome. So this chart also comes from J.B. West. And the gist and the highlight here is that the first 4 of those situations where we get hypoxemia will all correct to a certain extent with supplemental oxygen. Absolute shunt, again with pulmonary AVMs or ASDs, right to left shunts, will not correct at all with added FiO2 or adding supplemental oxygen, regardless of the delivery means or mode. So this, again, can be very high yield on written tests in terms of it will be a list of different type of pathophysiologies. They won't list this, but they'll list a clinical example, and they'll ask which all of the following will correct with an increase in FiO2 except. So this is a good thing to kind of go through, and I think we can roll through this in a little more detail this afternoon. So I think we'll finish up here. We'll take some quick questions, and then I unfortunately have to run to the ICU. But this all sounds nice on paper. You can really think through some of the mechanisms. It's interesting physiology and pathophysiology, but in the OR, if someone desats and is hypoxic, sometimes it's a little difficult to make the leap from the textbook mechanisms of what's happening to figuring out what's actually happening in the OR and most importantly, fixing it. So if someone gets hypoxic in the OR, it's not very useful to be thinking through all of these all at once and drawing out diagrams and figures and gradients. You need to take a very efficient and systematic approach because this is one of the things that we need to fix quite quickly. So people will typically take kind of a geographic approach to this. Oftentimes they'll start at the alveoli and work backwards to the machine, or they'll look at their machine, go down the circuit, and then look at the tube, and then the alveoli. So what this means is for people who will start at the alveoli, they will look at the patient, they will auscultate to see different etiologies of where we'll get this VQ mismatch. So what are some things that we'll be listening for and what will change management? So if someone desats, you start listening to them. What are you actually listening for that you might be able to fix? Okay, so what else if you hear only one-sided breath sounds? What can be on that differential? Pneumo, main stem. Depending what they're doing, a hemothorax, a big mucus plug. And then let's say you hear bilateral breath sounds, maybe you hear some crackles, pulmonary edema, maybe you hear wheezing, bronchospasm, things like that. So you can fit all of those into the different categories of those 5 categories of causes of hypoxemia. But clinically and in terms of intervening rapidly, it's just not an effective way to think through things. So this is why people will do this geographically. So after they auscultate, people will then look at the ET tube, essentially making sure that it's still connected to your circuit and that it's not kinked. They'll trace the circuit back, mostly just looking for a disconnect, and then looking at the machine and the monitor. So here we're looking at our inspired FiO2 to make sure we haven't had a line failure. We're looking to make sure we're getting end tidal back, that we're getting reasonable tidal volumes, that we've actually set our FiO2 to a reasonable number, and then looking at monitors. So sometimes people will desat and it'll just be a horrible pleth waveform and the pulse ox is barely hanging onto a finger, so that kind of stuff. So again, this is a practical approach to hypoxemia for the boards and for your own knowledge, and once you've made a diagnosis, having this approach to hypoxemia becomes important, but we always want to tie this back into what is actually going to matter clinically when you're taking care of someone. So I apologize, that was a little bit of a whirlwind and we had some tech issues, but are there any questions we can clarify at this point before we come back this afternoon? Sweet. And then we'll go around and introduce ourselves this afternoon. Sorry, this morning has been a little hectic, but it's nice to meet you guys. Welcome, and we'll have a little more time this afternoon. Thanks. Thanks.